So this is the activity for Chapter 19, where we're going to work through the questions found on your in-class worksheet. So Case 1, it's all Greek to me. Part 1. Dr. James Stevens is a pediatrician serving the Tarpon Spring, Florida area who is seeing one of his new patients in the clinic today. As Dr. Stevens enters the examination room, he says Kalimera to Stephania and Nikolaos Stamos, a greeting he uses with a number of his patients who are Greek American. Mr. and Mrs. Stamos have brought in their only child, beautiful little Nicoletta, who will be 1 year old in about 6 weeks. Nicoletta's parents are very concerned and tell the doctor that the baby has been acting strangely. The father, Nikolaos, is a personal trainer, and he suspects that Nicoletta has been anemic for some reason. Originally, Nicoletta had been on a low iron formula because she was experiencing gastrointestinal distress. The parents changed her formula to a high iron formula to see if it would help alleviate her symptoms, but Nikolaos tells Dr. Stevens that it did not. His daughter continues to suffer from general malaise and lethargy, and her skin looks a little pale recently. Nicoletta's parents also tell the doctor that their daughter looks bloated all the time and seems tired and cranky. Dr. Stevens notices that Nicoletta's belly appears to be swollen. Stephania mentions that she too noticed that about a month ago, but thought it was either gas or that the baby was gaining weight. Dr. Stevens also makes a note of the fact that her head circumference seems relatively large. Dr. Stevens advises the parents to switch Nicoletta back to her original formula and orders a CBC, complete blood count panel. Then, almost as an afterthought, he decides to order a radiograph of the skull. Something just doesn't look right about her head, he says to himself. So Part 1 questions. Number 1. What is anemia, and what types of disorders and deficiencies can cause anemia? So anemia is a condition of low oxygen delivery to the body's tissues. It can be caused by a low hematocrit, which is caused by not enough red blood cells. So for example, pernicious anemia is caused by a lack of vitamin B12. B12 is necessary for the erythroblast to develop during erythropoiesis. It can also be caused by reduced levels of hemoglobin or altered forms of hemoglobin. Hemoglobin is the oxygen-carrying protein in red blood cells. For example, sickle cell anemia from a hemoglobin mutation can cause anemia. The mutation causes the red blood cells to form a sickle shape, which interferes with the oxygen-carrying ability. Another example is iron deficiency anemia from a lack of iron. Iron is needed to make hemoglobin because it forms the center of the heme groups, and it is the part that actually binds to the oxygen. Dr. Stevens receives the lab reports and decides to refer Nicoletta to a hematologist. The results are as follows. So you can see hemoglobin levels was 5 grams per deciliter. The red blood cell count was 4.6 times 10 to the 6 cells per milliliter. The MCV, or mean corpuscular volume, which is the volume or size of a single red blood cell, was 65. The white blood cell count was 15,000 cells per milliliter, and the platelet count was 250,000. Number 2, are the lab results of the CBC normal? Which values are normal and which are not normal? So the patient's values are always given, and then you're always given the normal ranges as well. So if we compare the patient's value to the normal ranges, we can see that these are not normal lab results. So for starters, her hemoglobin value is far too low. So in females, hemoglobin should be between 12 and 15 grams per deciliter. Little Nicoletta's value is only 5 grams per deciliter. Her mean corpuscular volume, which is the average size of the red blood cell, is far too low. The mean corpuscular volume should be between 80 and 100, and Nicoletta's is only 65. And she has an elevated white blood cell count. The normal range should be between 4,500 and 10,000 cells per milliliter. She only has 15,000, or she has 15,000 cells per milliliter, which is over. Her red blood cell count and her platelet count are normal. Number 3, why are there different normal values for hemoglobin levels and red blood cell count in males and females? So if we look at that table that I just showed you, you might have noticed that for the hemoglobin and the red blood cell count, you were given a different normal range for males versus females, and again for the red blood cell count. And notice in both cases, the values for the male are higher. So males have a much higher level of androgens than females, and testosterone is the primary androgen. Testosterone stimulates erythropoiesis, which is red blood cell production, so men will have a higher red blood cell count and a higher hematocrit than women. Having more red blood cells means having more hemoglobin, because red blood cells are essentially packets of hemoglobin, so men will also have a higher level of hemoglobin in the hemoglobin count. Note, women can also have fluctuations in their red blood cell count throughout the month due to their menstrual cycles and loss of blood during that time. And some women can have menstrual cycles that are heavy enough to cause a temporary anemia during the weeks of their period. Number 4, do red blood cells normally have nuclei? Describe the structure of a red blood cell and how this structure facilitates the function of a red blood cell. So no, red blood cells normally do not have a nucleus or any other organelle for that matter. Red blood cells have a biconcave disc structure, and here's 3 different views of that. So here's a 3D model, here's a cross section showing how it's biconcave, so it dips in on both sides, and then here is a surface mesh model, so you can kind of see that as well. So this structure allows red blood cells to have a high surface area to volume ratio for more efficient gas exchange. It also allows them to have the ability to stack, to form these little stacks called rouleaux, which allows them to pass more easily through blood vessels. And it allows them the ability to bend and flex to pass easily through the smallest capillaries. So this is case 1, part 2. Mr. and Mrs. Stamos bring little Nicoletta into the hematologist's office, and Nicoletta has her blood drawn. After a few minutes, the hematologist returns to speak with the parents. Even with just a few moments looking at the sample, he knows that there is something wrong. The hematologist reports that he observed severe hypochromia and microcytosis, and also fragmented and nucleated red blood cells. The results are shown below. So on the left side, we have Nicoletta's red blood cells, and on the right side, we have normal red blood cells. So see if you can tell the difference. So number 5, use your Greek and Latin root words to determine what hypochromia and microcytosis mean. So this is where knowing multiple root words can help you figure out what words mean, even if you've never seen them before. So hypo is a prefix that means less or below or lower than. Chrome is a suffix that means color. So hypochromia would mean low color or lightly colored, and this refers to Nicoletta's red blood cells not being as fully red as they should be. So if you look at the left picture versus the right picture, you can tell that the color of Nicoletta's blood cells is not as deep and dark as they should be. Micro means very small, and cyte means cell, so microcytosis would mean small cell. It refers to Nicoletta's red blood cells being smaller than they should be. And we saw this on the CBC results as well. If you remember, when we looked at those results, she had a very low mean corpuscular volume, or MCV, meaning the volume of her individual red blood cells was too low. This is another indication that they are smaller than they should be. So number 6, do you think Nicoletta's red blood cells are healthy? Why or why not? What do you think her problem might be? So her red blood cells do not look healthy when compared to normal blood cells. Her red blood cells are too lightly colored, as we just discussed, and they are much smaller than normal. Now, if you remember from the blood results, she did have a normal red blood cell count, but she did have lower hemoglobin levels than normal, so she must have a problem with hemoglobin formation. So she's making red blood cells, but they aren't getting filled up with hemoglobin, and this is why they have a lighter color and a smaller volume. So red blood cells are essentially packets full of hemoglobin. So if you're not stuffing your packet full, it's not going to be as full or as colorful as if you fill it up with hemoglobin. So moving on to Case 1, Part 3. Dr. Stevens receives a full report from the hematologist, and he also receives the digital images of Nicoletta's skull shown below. So Nicoletta's skull is shown on the left side, and a normal skull is shown on the right side. So question 7, does the radiograph of Nicoletta's skull appear normal? How are the two radiographs different? And if you did have difficulties in seeing the differences, I found another image from a different patient, and I'll put it here. And so if you look at that for a moment, so this one is very similar to Nicoletta's, but it might be a little easier to see, and then compare those two to the normal one. So these are not normal radiographs of a skull on the left and the right. The one in the middle is. And so Nicoletta's skull has a distinct fuzzy edge around the border. So you can see it a small bit in hers. You can definitely see it in this other radiograph that I found for you. So Case 1, Part 4. Dr. Stevens calls Mr. and Mrs. Stamos and asks that they come in for a follow-up visit. After they are seated, Dr. Stevens informs them that Nicoletta's condition is very serious. She has a form of anemia called beta thalassemia major. This is a genetically caused anemia that results from mutations in the hemoglobin gene. This particular type of genetic anemia is prevalent among people of Mediterranean descent. So number 8, does Nicoletta's diagnosis explain her symptoms? Explain how the diagnosis explains the altered CBC values, the altered appearance of the red blood cells, and the abnormal skull radiograph. So they've just told us that Nicoletta's body can't make enough hemoglobin because she's got this beta thalassemia mutation. So let's see how all of her results that we've looked at so far fit in with this diagnosis. So her hemoglobin values are very low, and that makes sense if she has a mutation preventing her from making enough hemoglobin. The red blood cell count was normal because the problem is with making the hemoglobin and not the cells themselves. Since there isn't enough hemoglobin to put inside the red blood cells, the cells are smaller, as shown by the reduced mean corpuscular volume, and they have a lighter color as seen on the slide image. The fact that she had an elevated white blood cell count on her CBC was actually likely not due to white blood cells at all. So they use automated counters to do these CBCs, and these automated counters look for nuclei when counting white blood cells, because remember, white blood cells have nuclei, but red blood cells do not. But because of this condition, a lot of Nicoletta's red blood cells still had their nucleus, so the machine was likely miscounting them as being white blood cells. So her elevated white blood cell count was not an elevated white blood cell count. It was the machine mistakenly counting red blood cells that still had a nucleus. And her red blood cells still had a nucleus because they didn't have enough hemoglobin to help push the nucleus out during their development. And then the fuzzy region on the skull is actually due to the bone producing additional red bone marrow within the periosteum. Well, if you remember from last semester, that is the membrane that surrounds the bone. This is the body's attempt to overcome the anemia by having more bone marrow available to make more red blood cells. Number 9. What would you predict about the EPO or erythropoietin levels in Nicoletta's bloodstream? So first, let's review the triggers for erythropoietin production and release. So EPO is released whenever the kidneys sense low oxygen levels. So things that can cause the kidneys to sense reduced oxygen levels include anemia, when blood flow to the kidneys declines, when the oxygen content of air in the lungs decreases, meaning less oxygen in the blood, or when the respiratory surfaces of the lung are damaged, which again would mean less oxygen in the blood. So since Nicoletta has a type of anemia called beta thalassemia major, she most definitely has elevated erythropoietin levels in her bloodstream. And it's actually the constantly high levels of EPO that makes her body start to grow red bone marrow inside of the periosteum, which results in that fuzzy skull radiograph. So because she's not making enough hemoglobin, she's not carrying enough oxygen, so her kidneys are constantly sensing low oxygen levels, so she is constantly releasing EPO, so she would have high EPO levels. Number 10, describe the structure of a hemoglobin molecule. So I'll put a little picture up here. A hemoglobin, a single hemoglobin molecule, is composed of 4 protein subunits. There are 2 alpha chains and 2 beta chains. Each protein subunit has a heme group in the middle, so there are 4 hemes total per hemoglobin, 1 for each protein subunit. And then each heme group has an iron atom in an ionized form, so it's Fe2+, in the center of it. So again, because there's 4 heme groups, there are 4 iron atoms total per hemoglobin. And it is actually the iron atom that is going to form that connection or bond with the oxygen molecule. So as a note, with beta thalassemia anemia, there can be a reduced synthesis, or actually in some cases a complete lack of synthesis of the beta chains. So contrast this with sickle cell anemia, where a mutation causes an alteration in the beta chain, but you still get a beta chain. And it's just the alteration in the beta chain make the hemoglobin molecules clump together, which give the red blood cells the sickle-shaped appearance. With beta thalassemia anemia, in some cases you don't even make a beta chain, so all you have are the alpha chains. Untreated beta thalassemia anemia will lead to death. So number 11, an alternate name for beta thalassemia is erythroblastic anemia. Review the steps in the production of a red blood cell and explain the basis for the name. So the production of red blood cells, called erythropoiesis, takes place in the red bone marrow, also known as myeloid tissue. So we start with a stem cell called a hemocytoblast. This is going to become a myeloid stem cell, which is then going to become a progenitor cell, which is then going to become a proerythroblast. And at this point, we are committed to the red blood cell pathway. Then it's going to go through erythroblast stages, and it's during these stages that the synthesis of hemoglobin occurs. The final erythroblast stage is called a normoblast, and this is when you're going to kick out the nucleus. And this mostly is because at this point you don't need the nucleus anymore and you want to make room for extra hemoglobin. Then you have, after kicking out the nucleus, you have the reticulocyte, and this is the cell that will enter the bloodstream. And then after about 24 hours, it matures into a mature red blood cell, also called an erythrocyte. So, since the hemoglobin is synthesized during the erythroblast stages, this disorder, which involves a problem with hemoglobin synthesis, can be called erythroblastic anemia because the problem is happening during the erythroblast stage of the red blood cell development. And before we move on, I just wanted to sort of wrap up this particular case by letting you know that the beta thalassemia anemias are very serious. There are a whole host of complications that can be associated with them. For example, swollen spleens. They usually always have to have their spleens removed. You can also have troubles with the heart and the liver, endocrine disorders, infertility disorders, so a whole host of complications. And there are actually different forms. So there's beta thalassemia minor, beta thalassemia intermediate, and then beta thalassemia major, with major being the most severe form and minor being not as severe. And currently, the really only treatment you can look forward to is lifelong blood transfusions. They may also attempt a bone marrow transplant to introduce hemocytoblasts that don't have the mutation that can result in normal red blood cells. But then there are its own set of complications that come with bone marrow transplants. And there is current research into gene therapy or actually fixing the mutation directly by using genetic techniques. So in this section, section 2, we're going to look at blood typing. So Bob's blood type is B positive. Cynthia's blood type is O positive. Hayden's blood type is AB negative. Complete the following questions about blood typing. Number 1, draw a pictorial representation of a single red blood cell from each person, Bob, Cynthia, and Hayden. Indicate what type of antibodies might be present in each person. So I'm going to put the question up here at the top, and I'm going to write out the different blood types so we can reference them. Bob has B positive, Cynthia's O positive, and Hayden is AB negative. All right, I'm also going to draw a key, so I'm going to use different colors for antigens instead of shapes. It just makes it easier. So my A antigen will be blue, my B antigen will be green, and my RH antigen will be orange. So I'm just going to keep those same colors, and I'm going to draw the simplified version of antibodies, which is usually drawn in a Y shape. So my anti-A antibodies will be blue, my anti-B antibodies will be green, and my anti-RH antibodies will be orange. All right, now I'm going to divide my paper into 3 regions, and we'll start with Bob. So Bob is B positive blood type. So if I am going to draw his blood cell, one of his single red blood cells, I need to think about what type of antigens are on his blood cell. So type B positive means he has the B antigen because he's type B, and he has the RH antigen because he's positive. So I would draw his blood cell with the B antigens, which are the green circles, and the RH antigens, which are the orange circles. So this is what Bob's red blood cell would look like. Now let's look at Cynthia, who is O positive. So again, let me think about what type of antigen she would have. She would only have the RH antigen. So type O means no A and no B, but the positive means she has the RH antigen. So if I draw her blood cell, I'm only going to draw it with the RH antigen, so I'm only going to put the orange circles on it. And now let's look at Hayden, who is AB negative. So he's going to have the A antigen, he's going to have the B antigen, because he's A and he's B, but because he's negative, he is not going to have the RH antigen, so his red blood cells will have the A in blue and the B in yellow and green, but he will not have the RH antigen. All right, so that's the pictorial representation of the single red blood cell. Now let's indicate what type of antibodies might be present in each person. Remember, you don't have antibodies in your own body to antigens that you have in your body. If you did, they would attack those antigens. Sometimes that does happen, and it's called an autoimmune attack, but we don't want that to happen. So Bob would not have anti-B antibodies or anti-RH antibodies. However, because Bob does not have the A antigen, he would have anti-A antibodies in his plasma. Cynthia has only the RH antigen, so she is not going to have anti-RH antibodies, but she will have anti-A antibodies and anti-B antibodies since she does not have those antigens on her red blood cells. And then Hayden will not have antibodies to his A and B antigens, but he might have anti-RH antibodies if at some point in his history he has become sensitized. So remember that the Rh antibodies are the one exception. You have to actually be exposed to the Rh antigen before you start making the antibodies, but we have no idea what his history was. So we're going to assume that at some point he could have been sensitized and that he now has anti-Rh antibodies. So number 2, fill out the chart below showing what blood typing test results would look like for each person. So I'm going to put my little key down here. So when I'm looking at blood typing, I'm only really caring about what antigens are on the red blood cells. So I'm only going to put the key down here for the antigens, and we'll start with Bob. So remember, Bob was B positive, so Bob had the B antigens and he had the Rh antigens. So when I put a drop of Bob's blood onto this part of the card where there are anti-A antibodies stuck on the card, the anti-A antibodies are not going to see anything to react with because there's no A antigen on Bob's cells. So you will not get any clumping or clotting in this spot. However, if I put Bob's blood here in this spot where there are anti-B antibodies, these anti-B antibodies are going to see these B antigens on his blood cells, and you are going to see clumping and clotting in that spot. Likewise, if I put Bob's blood over here in this spot is coated with anti-Rh antibodies. They are going to see the Rh antigens on Bob's blood cell, and so you are going to get a reaction and you will see clumping or clotting. So if I put Bob's blood on this card, I would have no clumping, clumping, and clumping, and this would tell me that he is B positive. All right, let's look at Cynthia. And again, let's remind ourselves what her blood cell looks like. She is O positive, so she has Rh antigens on her blood cell. So in Cynthia's case, again, there is nothing for the anti-A antibodies to attack, so nothing is going to happen here. There is nothing for the anti-B antibodies to attack because there's no B antigen, so nothing is going to happen there either. However, the anti-Rh antibodies are going to see these Rh antigens on her blood cells, and I will get clumping or clotting in that last spot. All right, and then finally let's look at Hayden. Remember, Hayden was AB negative, so he has A antigen and B antigen. So now when I put Hayden's blood here in this spot, the anti-A antibodies are going to see these A antigens, and I'm going to get clumping or clotting. If I put a spot of his blood in this second spot, the anti-B antibodies that are on the card are going to see the B antigens on his blood cell, and I will get clumping or clotting. But in this case, he doesn't have any Rh antigens, so there's nothing for the anti-Rh antibodies to react with, so that cell will stay unreacted. So that is, we kind of did the blood typing in reverse. We knew what the blood types were, so we figured out what the test results would be. But then you can also go the other way and know, for example, that if I do see clotting in the A column and the B column, but not in the Rh column, that person must have A, B, negative. So question number 3, can Cynthia give blood to Bob? Why or why not? So I'm going to put a reminder of Cynthia's blood type up here. She is O positive. That means she has the Rh antigen, but she's also going to have anti-A antibodies and anti-B antibodies. I'll also put Bob up here as a reminder. Bob is B positive. He has the B antigen and the Rh antigen, and he has the anti-A antibody. So the question is, can Cynthia give blood to Bob? And as we discussed in the lecture, when you're trying to consider if one blood type can give to another, you have to most importantly consider the donor's antigens compared to the recipient's antibodies. So Cynthia has Rh antigens. Bob does not have anti-Rh antibodies because he also has the Rh antigen. So nothing in Bob's plasma will attack Cynthia's red blood cells, so it is safe for Cynthia to give blood to Bob. Now, Bob does have anti-A antibodies, but so does Cynthia. So Cynthia does not have the antigen. And remember, antibodies attack antigens. So there are no antibodies in Bob that match antigens on Cynthia's red blood cells. So this would be a safe transfusion. Number 4, can Bob give blood to Hayden? Why or why not? So again, there is Bob with his B positive, and Hayden has AB negative. So he has the A and B antigens, and he has the potential to have the anti-RH antibody. So the question is, would this be safe for Bob to give blood to Hayden? So again, I'm going to remind you that when you're looking at matching blood types like this, you want to consider the donor's antigens compared to the recipient's antibodies. So Bob has RH antigens, the little orange circles, and B antigens, the green circles. Hayden has the potential to have anti-RH antibodies. We don't know if he was sensitized at some point, but we're going to go on the assumption that he was. So it's always safest to make the assumption that he has the anti-RH antibody. So Hayden's anti-RH antibodies could attack these RH antigens on Bob's red blood cells, making all of Bob's red blood cells start to undergo hemolysis. And that would be dangerous for Hayden, because not only would his antibodies be destroying the blood he just got, but now all of those blood parts and stuff floating around could cause clots that could lead to stroke or heart attack. So no, this would be a dangerous match, and Bob cannot give blood to Hayden. Number 5, does Cynthia have to worry about hemolytic disease of the newborn if she gets pregnant? Why or why not? So again, here is Cynthia. Cynthia has the RH antigen because she's O positive, and she's got the anti-A antibodies and anti-B antibodies. So no, Cynthia does not have to worry about hemolytic disease of the newborn. And that is because hemolytic disease of the newborn occurs when a mother has anti-RH antibodies that cross the placenta and attack the baby's RH antigens. Right? So the babies are never going to have RH antibodies for it to go the other way, because by the time the baby gets sensitized to the RH antigen, it will be out of the mother's system. So you only have to worry about the mother having anti-RH antibodies that will attack the baby's RH antigens. Cynthia is never going to make anti-RH antibodies because she has the RH antigen on her red blood cells. So she's never going to make the antibodies, because otherwise they would attack her blood cells and quickly kill her. So this will never be an issue for her because she's never going to make anti-RH antibodies. So the bottom line is, it is only RH negative mothers that have to worry about this. And because Cynthia has the little positive here, she's O positive, that means she is RH positive and she does not need to worry about this. So this is section 3, injuries. So Steve is very active with his school soccer team, but as with any active person, Steve occasionally ends up with cuts and bruises from his activities on the field. Last week, Steve both cut his shin and got a nasty bruise on his forearm. Although the cut on the shin quickly stopped bleeding, Steve was not able to wash it and bandage it before he got a mild infection in the cut. After treating the cut with antibiotic ointment, it quickly healed. The bruise on his arm, however, has taken longer to heal. It started out as an ugly purple-black color, but over the days since the accident, it has turned greenish and then yellowish, and then it finally disappeared. Number 1, explain the process of hemostasis that occurred after Steve cut his shin. Then describe the production of platelets. So the first phase after you break a blood vessel, so the first phase of hemostasis is the vascular phase. The damaged endothelial cells, which are the simple squamous epithelial cells that line blood vessels, release endothelin and other chemical factors and hormones. These cause vascular spasm, which is contraction of the smooth muscle in the vessel walls, and this also causes the endothelial cells to become sticky. Phase 2 is the platelet phase. Platelets adhere to the sticky endothelial cells. As they arrive and stick, the platelets are activated, causing them to release clotting factors and other chemicals. These chemicals attract other platelets to the area who also become stuck, forming a platelet plug. Then there is phase 3, the coagulation phase. You have both intrinsic and extrinsic clotting factor cascades, which converge onto a common pathway with the ultimate goal of producing an enzyme called thrombin. Thrombin will convert the soluble fibrinogen in the plasma into insoluble fibrin. Other formed elements and debris become trapped in the insoluble fibers that are formed by fibrin, forming the blood clot. Clot retraction occurs when the accumulated platelets contract, pulling the edges of the wound together. And then fibrinolysis is the dissolving of the clot after the healing repairs are complete. So here is an image to show you the different steps. So we started with the vessel injury. The first phase is the vascular phase. So this one you're going to have the spasm and the release of the endothelins by the endothelial cells. Then you've got your platelets coming. They adhere to the injury site. They aggregate. They stick to each other and to the walls, and they form the platelet plug. And then you get the clotting factor cascades that converge on the central pathway, which ultimately results in thrombin, which converts fibrinogen to fibrin, and you get the little fibrin strands, and then a bunch of stuff gets stuck in there, and that forms the clot. And then for the last part of the question, describe the production of platelets. Again, we're going to start with hemocytoblasts in the red bone marrow. These are going to differentiate into myeloid stem cells, which are going to change into a progenitor cell. In the case of platelets, the progenitor cell goes on to become a large cell called a megakaryocyte. The megakaryocyte spends a few days making a bunch of enzymes and the clotting factors, packaging them up into little vesicles, making extra membrane, and then it starts shedding off pieces of its membrane, and those become platelets. So one megakaryocyte can make about 4,000 platelets. Number 2, some bacteria must have gotten into Steve's cut. What white blood cell would you expect to arrive first to the injured site? Explain how this white blood cell gets to the injured site. How will this white blood cell neutralize the bacteria? So neutrophils, which are the most numerous of the white blood cells, are also likely to be the first to arrive. So we're going to use this little picture to explain the steps, and there's some extra stuff going on in this picture, but just focus on where I'm going to put the numbers. And then I didn't put a number for this one, but remember your white blood cells for the most part are also formed in the bone marrow. Lymphocytes are an exception because they do go to lymphatic tissues, but we're going to cover that in chapter 22. So first you have circulating neutrophils that are going to follow chemical signals to the site of injury or infection. This is called positive chemotaxis. Next, those neutrophils are going to marginate, which means they attach to the vessel wall as shown here in the image. So that's step number 2. Then the neutrophils immigrate out to the tissues by squeezing in between endothelial cells. So you can see that at number 3 here. The neutrophil is squeezing out between 2 endothelial cells to get into the tissues. It will then follow the chemical trail again, and it's going to use amoeboid movement, sending out the little pseudopodia feet to get to the bacteria, and then they will phagocytize the bacteria, which is shown up here in number 4, where you can see phagocytosis is in the process of engulfing this little bacterium. Number 5, they will undergo a respiratory burst to release highly reactive molecules like hydrogen peroxide and superoxide anions. And they will also use enzymes and molecules called defensins in the lysosomes, which are shown in these little green dots, to break down the bacteria once it's inside the cell. And then they will also release chemicals, which are called cytokines, to attract other immune cells to the area to help fight the bacteria. Also shown in this picture, and which your textbook doesn't go into detail and you won't be tested over, but neutrophils also have the ability to create these little nets of fibers that they can use to trap bacteria in as well. Number 3, what if a parasite had entered Steve's cut instead of bacteria? What white blood cell would you expect to lead the fight, and why? So eosinophils are better suited to deal with parasites. Eosinophils can release toxins by exocytosis so that they can surround and kill a much larger multicellular organism by using this method. So I gave you a few pictures in the main lecture video, and I also showed you a little video. And here is another picture. So a helminth is a type of parasitic worm. And so again, it gets surrounded by the eosinophils who release these little granule proteins and reactive oxygen species that are going to be cytotoxic to the worm and kill it. And then number 4, explain why Steve's bruise went through several color stages. What molecules were responsible for the color of each stage? What will happen to the yellowish colored molecule? So put a little picture here for us to refer to. So the initial bright red color you have right after you get a bruise is due to the oxygenated hemoglobin in the red blood cells that have leaked out of one or more broken blood vessels in that area. Then it's going to change to purple as the oxygen is released from the hemoglobin. So remember, deoxygenated hemoglobin is a dark red, which can appear blue or purple through the skin. Macrophages are going to be in the area by this point, and they're going to start cleaning up the red blood cells. And after the macrophages engulf the red blood cells, they are going to start breaking them down and recycling their contents. The heme group, after it's had the iron stripped from it and the iron is recycled, the heme group is broken down into biliverdin, which has a green color, and that's going to give the bruise a greenish tint to it. And then the biliverdin is then changed into bilirubin, which has a yellow color, which turns the bruise a yellow. The bilirubin is then released into the bloodstream by the macrophage, where it will be filtered out by the liver. The liver is then going to add the bilirubin to the bile, which is then secreted into the intestines, where it will ultimately be discarded in the feces. And while it goes through the large intestines, it's converted into some other molecules, urobilins and stercobilins. The stercobilins have a brown color, which is what gives our feces its brown color. And that is the end of the Chapter 19 activity.